And with no further ado, I would like to welcome Torrie Fields. Torrie, here's a lei for you. We obviously can't get you one in person. We're sharing with you a beautiful lei also as a sign of our thanks for coming and talking with us today. Torrie Fields is a MPH like me, yay, go public health. She's a consultant for health plans, purchasers, and academic centers, evaluating the impact of care models and clinical workflows on achieving the Institute for Healthcare Improvement's triple aim. She currently serves as a strategic advisor to the Center to Advance Palliative Care, known as CAPC, the Coalition to Transform Advanced Care, which is C-TAC, Center for Healthcare Strategies, Better Care Playbook, and the National Academy for State Health Policy. Her work includes analysis and development of state and federal policies that improve access to high-quality care for people with serious illness and their caregivers. She works with state Medicaid agencies across the country to develop and evaluate care models and benefits, and with federal agencies to incorporate best practices into care model design and implementation. Very importantly for us, her work includes the design and implementation of community-based care benefits here in Hawaii, as well as in California. And she is working on workforce development projects to improve the lives of people with serious illness and their caregivers in Oregon, New Jersey, and New York. So Torrie, thank you very much for coming today. We're really pleased to have you, and take it away.
Oh, thank you so much. Aloha, everybody. And thank you for introducing yourselves already. I am going to share my screen. So as spent a lot of time thinking about how to optimize billing and coding, very much like Jeanette, I don't like fundraising. I like things being sustainable, which means that sometimes, you have to actually bill for your services. And these rules for advanced care planning change all the time. So there is a group of folks who are somewhat crazy like me, and they are part of the Coalition to Transform Care. And we track the physician fee schedule to make sure that we have the most up-to-date information on how advanced care planning is being billed for today, and what are some of the rules around needing that you need to know in order to do that effectively. One of the really interesting things that happened recently was the release of the Office of the Inspector General, OIG, report on advanced care planning billing codes. And what they found was that a fair number of advanced care planning billing codes and billing efforts actually did not follow the rules. The punchline, so why, after all this investigation, what they found was that the rules were just not very clear about what you need to do in order for advanced care planning to count. And this presentation is an effort to help give you some tools to know exactly what you need to do to document and to code for advanced care planning. At the end, there is going to be some FAQs, etc. And I am going to spare you from reading everything on every slide, but you will get these slides afterward as well, and we'll have those FAQs as part of this presentation. Learning objectives. I'd like to provide some awareness about the opportunities that clinicians have for reimbursement for advanced care planning. This is not just for physicians, this is also for your LCSWs, for your social workers, who are also able to bill for advanced care planning in certain circumstances. I'd like to share some information about how to bill and document for qualified advanced care planning visits. And then we are going to end with some high-level information about this new benefit that Jeanette has been, tantalizing you about with this palliative care benefit, where advanced care planning is included, but it's a bigger palliative care package. I am not a billing and coding expert, so just want to give you a disclaimer there. I'm quite good at optimizing revenue for practices and in making sure that billing and coding is accurate, but make sure you also consult with a certified coding consultant. That's me. Jeanette already introduced me. So let's get to it. The first thing to really understand is that there are a certain group of codes that really are optimized around time. What we know is that counseling and care coordination and advanced care planning take a variable amount of time depending on the complexity of the patient. So these are codes that are time-based. It's the first thing to remember. So you're going to want to get really good at documenting the start and stop time of your conversations with your patients. Despite being distinct activities, care coordination and advanced care planning can occur at different times during the same encounter or as a patient's needs dictate. So you can actually bill for both of these things. When more than 50% of the practitioner or patient and or the family encounter time is spent counseling and or in coordinating care, time becomes the controlling factor to qualify for a particular level of evaluation and management. For both counseling and care coordination, it is important to clearly describe the details of the activity that you're discussing. Counseling sessions should clearly document who participated, where and when it occurred, and likewise, what topics were discussed, what decisions were made, and how these decisions will be implemented should all of those things be documented. Remember that when these activities occur in an outpatient setting, the documentation must include a statement that affirms that the patient was present and they were face-to-face with a practitioner. Documenting care coordination activities must be equally specific to ensure that the other members of your interdisciplinary team are able to integrate any changes in the care plan and work on behalf of the patient. This is one area that illustrates the critical importance of adhering to the basic fundamentals of documentation.
So I'm just going to interrupt you, Torrie. I'm looking at counseling and care coordination as a slide.
Yep.
Okay.
That's fine.
Is that where we are?
That's where we are.
Sorry, I just had a couple other people ask me that question too. So good, carry on. Sorry to interrupt you.
Much of the success of the activities that we'll be talking about is dependent on your ability to document the event clearly and competently. So these are the things that if you're having an advanced care planning or a counseling conversation, these are the things that you are going to want to document. So diagnostic results, that you discussed these things, that you discussed prognosis, risks and benefits of treatment options, instructions for treatment or follow-up, importance of compliance with treatment options, and how you would reduce risk factors. So this is a conversation. It's not just documentation. These notes also need to be legible and accurate and relevant, and you need to sign them. I hate to say that, but you need to sign them. That's going to be really important. A lot of the things that we found is that there was a lot of documentation about these conversations, but they didn't really go anywhere and they were not legible or signed. So let's get into advanced care planning. Advanced care planning, when done by physicians and other qualified professionals, such as nurse practitioners and clinical social workers, often occurs at multiple times throughout a person's course of treatment and throughout their palliative care journey. And they can occur many times in concert or in relation to somebody else's other planned activities, like a standard office visit. It's important for practitioners to avoid commingling advanced care planning with evaluation and management services, because both of these things are specialized services requiring a skilled professional, and each activity should be valued separately in order for you to get credit and to illustrate the detailed level of specialized services that a person actually received. Be aware that when the patient and family indicate that they want to discuss advanced care planning and goals of care within an evaluation and management visit, this can then trigger your ability to be reimbursed for an advanced care planning documentation. Make sure, as I shared earlier, that you note the time and that you segregate the advanced care planning discussion appropriately so that you can build out the time for the evaluation and management and the advanced care planning separately. That's where there's some tricky math that can occur sometimes. In doing so, the documented information you capture will need to be specific, accurate, and complete. And you will be able to be credited for both an E&M code and advanced care planning, provided that you're able to document these things clearly. So these are the 6 bullets that you need in order for your advanced care planning documentation to count. So document the advanced care planning time and services separately from your office visit or your E&M code. Use a start and end time to accurately capture billable time. Document who was present in addition to the patient. So did they have a caregiver? Did they have multiple caregivers? Who was actually present for this conversation? And then document the specifics of the discussion, what was discussed. Facilitate interdisciplinary team communications, meaning share that advanced care planning chart note. And when you are discussing these goals for care, you're actually able to be billed separately for the office visit and advanced care planning. Your team is going to thank you if you're able to count for both. Before we take a look at encounter-based billing, I thought it would be best to provide you with a list to help you clarify when somebody should actually bill for their time. So as you review the list of billable activities, you'll find that many of them occur in conjunction with other activities. Please be sure to be accurate in the time that you're recording and make sure to clearly document the nature of the activity. So all of these things can actually be counted as time-based billing. For example, in preparation for somebody's visit, you may have reviewed results from somebody's latest CT scan, confirming that a bone metastasis has expanded to include the left hip and the sacral spine. Another reminder is that teaching, which is generally not part of a discussion or topic leading to a discussion, is not billable. So in order to really document for advanced care planning, you're documenting only for the conversation that you're having with that person. In a hospital or a facility, there are time-based billing codes. So this is really an intention to give you some clear information and direction about the times when time-based billing can be used. And advanced care planning is really one of those times. So you can use advanced care planning, the billing code for advanced care planning, when more than 50% of the face-to-face encounter with the patient and or family was spent on counseling and or care coordination. You can do that in the hospital and or the nursing facility, and you need to ensure, one, that you're documenting the total length of time and where that encounter occurred, the time spent on advanced care planning, and a description of the advanced care planning topics that were discussed. Advanced care planning uses 2 billing codes only. The first code is 99497, and that must always be entered first because it indicates the first 30 minutes of time that you're spending doing advanced care planning. You must complete a minimum of 16 minutes of discussion time in order to use the 99497 code. When the discussion continues beyond the initial 30-minute period, the practitioner should use the code 99498 for the next 30 minutes, which is eligible once 16 minutes of that time has elapsed. After that, the practitioner should use 99498 for every 30-minute time interval once that time has been exhausted. So these are different blocks of time. You use the 99497 for the first 30 minutes, and then for every 30 minutes after that, you tack on the 99498. Don't get confused in terms of the minimums. Really what you're focusing on are those 30-minute blocks of time. In order to have time documentation count, this is, there's a good encounter on the left and a not so great encounter on the right. On the left, it counts when a practitioner is able to show that 2 distinct services were provided and can claim credit for the palliative care services that were provided. As you can see in the incorrect version, neither a colleague nor anyone attempting to audit for documentation of this encounter would be able to tell how much of the encounter time was actually devoted to advanced care planning. So you can have a pretty short chart note as long as you share that you have 110 minutes total with 50 minutes of that on advanced care planning. That allows you to bill for both. It's inevitable that sometimes palliative care providers have prolonged services that extend beyond the customary time for a patient encounter. There are billing codes available that accommodate and recognize the value of those extended services. We've outlined the requirements for you to help you understand when they can be used and by whom, as well as a direction of what specific code should be used for an initial or subsequent nursing facility visit. So this is something that's often done in addition to advanced care planning. All right. So in terms of the brass tacks on advanced care planning, who can bill and how? Physicians and non-physician practitioners, NPPs, can bill for advanced care planning. Advanced care planning has expanded from the outpatient clinic to now include advanced care planning that can be billed in the hospital and advanced care planning that's billed in the home setting, and in certain circumstances, billed in telemedicine. There have been some recent revisions to direct supervision rules, which actually expands some of these services to make it allowable for LCSWs to actually bill more easily for advanced care planning. You'll see those here. People who have an NPI, ultimately. There are also incident to billing rules. And incident to means that an advanced practitioner or an ND can start a visit. A social worker can continue that visit for advanced care planning, and that social worker can actually bill under the physician billing NPI for that advanced care planning. And there are some rules around who actually qualifies as an NPP. So we can send a link at the end of this in terms of who qualifies for that. But one of the groups who qualify for this incident to billing rule is a clinical social worker. Oftentimes we don't know exactly what a clinical social worker really is. The required qualifications is that you really need to be an LCSW and have completed your training. There are certain rules around coverage criteria for which LCSWs can actually bill and is considered a licensed clinical social worker. But what's important here for advanced care planning is that these licensed clinical social workers can be paid at 75% of the clinical practitioner's fee schedule for advanced care planning. So social workers can be doing this work as a part of the team and be paid for it. And this is really important when we think about what counts as advanced care planning. The accepted conversations that count under the reimbursement for ACP are discussions around healthcare options, reviewing and refining goals for care, deciding among options for treatment, discussing documentation, picking a proxy, and completing forms. So these could be a wide variety of discussions that one could have that can be reimbursed to count as advanced care planning. Again, there are only 2 codes that are related to advanced care planning. One is the first code and one is the add-on time code. This 99497 for the first 30 minutes and 99498 for the additional 30 minutes. This is around $85. So you see $86 for non-facility, $80 for facility for that first 30 minutes, and then $75 for every additional 30. In order to use both codes together, you need to have spent at least 45 minutes on an advanced care planning conversation. So even if you spend 3 hours or 4 hours on advanced care planning, you can continue adding up that time block. For incident to billing and direct supervision, this definition is that it requires a physician to be physically present in the office suite and immediately available to furnish assistance and direction throughout that discussion. So if an LCSW is having a discussion in the clinic, the physician needs to be in the clinic at that time. Doesn't necessarily need to be in the same room. One of the major changes during COVID that is not going to be revised under the public health emergency is that direct supervision can be met if the supervising physician is immediately available to engage via FaceTime. So you don't necessarily need to be in the same room or in the same office or physically present as a social worker and a physician to have a social worker bill for advanced care planning under their physician oversight. This is super important. There are other things that are in the that have been changed in terms of incident to billing. So first, there are no Medicare regulations that prohibit eligible distant site practitioners from billing for telehealth services provided incident to their services, which means that you can be in someone's home as a social worker, have advanced care planning conversation, and bill incident to your medical oversight if they're available via your phone. Under the new definition, CMS actually has clarified that services can be provided incident to via telehealth, and that a physician only needs to be present virtually. So now they actually have clear guidance around this. In addition, on the 2020 fee schedule, the CMS actually broadened modifications to the medical record documentation requirements for physicians and for NPPs. And NPPs, qualifying NPPs, are now able to review and verify documentation entered into the medical record by members of the medical team. And that includes advanced care planning as well. So LCSWs are also able to review advanced care planning documents. A couple of things to know about the audit process and advanced care planning, billing, and documentation. Number one, first thing to know is that in terms of billing, the folks who actually audit are called the MACs. They're the Medicare Administrative Coordinators, and they're the local folks who actually look at the billing practices in your area. They make things called local coverage determinations, and that's where the rules around documentation for advanced care planning lies. Which is sort of a challenge because that means it can sort of vary everywhere you go. There are really loose rules around advanced care planning. So there's no specific format required by CMS for any of your documentation, but you need to include these 6 things: time spent in minutes, the location of the service, who received the service, and that includes everyone, people who were involved in the conversation or discussion, summary of the discussion, and if another provider performed the discussion, identify the physician oversight. You actually can make checklists. There are a number of them out there. And dot phrases can be put into the electronic medical record to actually meet these requirements more easily. I'd say really try and focus all of your time on the summary of the conversation rather than all of the other components that can be tracked a little bit easier. Some frequently asked questions that I usually get. First thing, patients do not need to be present in order for you to bill for an advanced care planning conversation. You can have an advanced care conversation with a surrogate and be reimbursed for that. You can provide advanced care planning telephonically due to some of those oversight changes that we discussed. And you can provide advanced care planning through telehealth, but there are some restrictions around audio only. More than one provider is able to bill for advanced care planning in any given period. There are no maximums around how many times somebody can enter into an advanced care planning conversation. So don't worry about whether or not somebody is getting 2 or 3 of them a week, or even by 2 or 3 doctors. There is no limit to which provider specialties can actually bill for advanced care planning. So this can be a primary care provider, an oncologist, or a palliative care provider. And there is no limit to the number of times that you can bill this code or the amount of time that you can bill for it, as long as you are documenting that you had that conversation for that length of time. Advanced care planning was also built to be billed together with other routine visits, like an evaluation and management code or an office visit. So they are supposed to be bundled. Start and stop time when that occurs is not necessary. So if you do have an office visit where you are having advanced care planning, you don't need to designate start and stop time. You just need the total amount of time that you spent doing ACP. That's a lot of stuff. Couple more things. The bottom bullet is the most important here. Because most palliative care social workers deliver care as part of a specialty team, some patients may receive a bill for a copay or coinsurance if billing is not completely correct. Please remember to apply the correct modifier for advanced care planning, which is this -33, so that advanced care planning can be counted as preventive, even when people have a serious illness. If a modifier is not applied, some patients will receive up to a 20% copay. It is important in your practice to have a script or a plan to discuss with the person, hopefully before the visit, if a copay might be incurred for advanced care planning. Especially in the nature of social work, that's really, really important. And it maintains trust with the patient and the family. Key takeaways. Document your time when you're performing advanced care planning and not when you are charting. A lot of the time in doing audit reviews, we saw a lot of 2 and 3 in the morning for the advanced care planning time. I'm sure that's when the charting occurred, not when the conversation did. Bill for both visits on the same day. So if you have an office visit or a home visit, and an advanced care planning conversation, bill for them both. And make sure you identify where the patient was when the care took place. So if you're doing telehealth, make sure you're documenting where the patient is, not necessarily where you are. Use a checklist and dot phrases to make sure you have those 6 bullets of information every time. And make sure that you have a script for schedulers and for social work staff for when somebody might receive an unnecessary copay. Make sure you follow the National Consensus Project clinical practice guidelines for when you're having these goals of care conversations. And I know that Kōkua Mau spends a lot of time helping support the actual discussions around advanced care planning. I provided some really helpful links here, and I'll share some additional information. And before I go to questions about the ACP billing, I'm going to touch really quickly on, just checking time. Yeah. I'm going to touch really quickly on the future. So there are some things still in flux with this new community-based palliative care benefit. The palliative care benefit is going to be something that will be available, hopefully coming to a theater near you, for all MedQuest members. So that is for all members who are covered by Medicaid, over 65, under 65, and children. And this, regardless of who their managed care plan is. And so there are some goals that MedQuest has in developing a community-based palliative care benefit. These are things that you probably are quite familiar with. We want to make sure that we have health equity for people with serious illness, and that people actually get the care that they want and that they need, and that they're actually able to access care that's available to them. And we also want to improve quality of life, decrease symptom burden, and also reduce all of the unnecessary in and out of the hospital that none of us really are excited about. There's a timeline for this work. We're sort of at the bottom. We're currently negotiating with CMS, et cetera. And Kōkua Mau and Respecting Choices, who are also here on this call, as well as Hui Pohala, are working to develop an implementation plan. And we're hoping a little bit later this year, we'll start to work on implementing this benefit. So what do you need to know about reimbursement? Reimbursement is for a bundle of services. The services are for assessment, for clinical services, and for care coordination and communication, including advanced care planning. and it covers a full interdisciplinary team, 24/7. And for children, it also covers child life specialists so that we can really make sure we're adapting services to kids. We are really focusing on this being a specialty care model. And so this will require palliative care specialty oversight for teams. And the reimbursement structure is going to be a little bit of a blend between fee-for-service and your, things that you see in hospice. And that means that there will be it will be a per member per month case rate payment, where there's one payment that will be one code that will be billed for all of the services that are delivered in that month. There's also a proposal for an additional assessment, and that additional assessment is not advanced care planning. It is more like a comprehensive assessment to better understand a person's goals for care. And so what we're hoping is that this comprehensive assessment for a person's goals for care, coupled with somebody's advanced care planning conversation, can really allow us to start to get a lot closer to what we have been hoping that advanced care planning can be, that it's something that is about documentation and picking a proxy, but it also is about clinical decision-making and really documenting care needs. So this is a little preview of how these codes will be laid out. There will be flexibility for those who are billing on a CMS 1500, so for professional services, and for those who are billing on a UB04, which is sort of what you're seeing here. The revenue code set is for pre-hospice palliative care services and would need to be billed in combination with the CPT codes that are specific to the assessment and the delivery of services. So you'll see those on the right. For those who are in a professional practice and are seeking to really start to deliver palliative care services through a team, you would need to then bill the HCPC code, but not the revenue code, and they would end up processing the same. So we're hoping to make it relatively simple and give a bit more technical guidance moving forward as we get more approvals coming. But this is sort of the preview of what palliative care billing and coding might look like in Hawaii. All right. And with that, I will take questions, and please feel free to also email me with any questions afterward, and I will make sure to get back to you.
Well, thank you very much, Torrie. That was a good start. I'm sure that there are questions out there. Folks can either put them into the chat, or people can raise their hand and we can call on you. There was, to start us out, Melissa Borges had a question. Are payments paid under Medicare Part A or Medicare, or are paid under Medicare Part A or Medicare Part B providers?
It's so funny, Melissa. I knew that someone was going to ask me that really early. This is really for Medicare Part B. So for most of the providers that I know who are set up as a home health agency or set up as a hospice agency, they use their Part B license in order to bill for advanced care planning.
Okay, good. Thank you. And you did share that these slides I can send them out to people, so you can let me know, folks, and I can forward those on to you. Okay, good.
2 more questions I see. Melissa, you also asked, will billing codes also be credited to quality metrics, like the Medicare STARS metrics? So it's interesting, great question. So advanced care planning is not part of the Medicare STARS metrics. However, Advanced care planning is a required metric of all hospital systems in the country. And it is a required metric as part of the dashboard for the Medicare incentive payment system. So this is something where hospital systems actually get an increased revenue if they hit their targets for certain things. Advanced care planning is one of them. So there are quality incentives. It's just not quite yet in the Medicare Stars arena. The other question is about the billing codes. Will the billing codes apply to all lines of business or MedQuest only? For the palliative care billing codes, what is proposed is only for MedQuest. However, what I am imagining is going to happen is really a transition or a changeover for any of those commercial insurance companies or Medicare Advantage plans who are delivering or are planning to deliver a palliative care benefit or a service. They're going to want to do everything the same way. It's hard to do different things for different people.
Well, Torrie, you seem to have answered all questions, which I find totally amazing since I'm already back on the wait. What was that?
Oh, well, I hope so. I hope I answered all your questions. Please let me know if there are any other questions that you have moving forward.
I did get a private question. If you have an idea about the timing of our new MedQuest benefit, I can tell you that people are really excited about that. And then another question that I did get was difference between the initial assessment and the reassessment in the palliative care. Palliative care services benefit. So Torrie is teaching me to use the right terminology. The MedQuest benefit will be called the palliative care services benefit. Is that right?
That's right. And I'll give you the nerdy reason. So this major category description is a description of the revenue code, and the revenue code per CMS already there is called pre-hospice / palliative care services. So that's the term of the benefit because we're aligning it with what the reimbursement really is called. That's the only reason that we're calling it that. You can call it supportive care or whatever you'd really like to call it, honestly, as long as people want it and accept it and you bill it as palliative care services, that's fine. So those are the codes. So the assessment, initial assessment, and the reassessment. For those of you who deliver community-based palliative care or any type of palliative care, what you know is that this population is a population that changes and they have ongoing decline in function. And so through all of the research and literature, what we found is that you need something that allows for a reassessment, which what we would say is once every 3 months or when goals for care change. And that would then allow for us to have a more comprehensive conversation and an assessment when somebody maybe needs to graduate from palliative care and you need to coordinate care there, or if somebody needs to move from palliative care to hospice, or any of those transition points. That allows you to really reassess the person and determine if that's the right program or a configuration of services for them. So that's the difference between the initial and the reassessment. In terms of the timeline, what we are hoping for is to be able to implement or have a start by 1/1 of 24, so that we have an implementation period of this year.
Oh, I had somehow understood it was kind of as soon as it's approved. No, so we wait until just January of next year?
It's a longer conversation, mostly to try and say that we want to make sure that it's set up and that we're not back reimbursing for things that weren't set up for, or optimized beforehand. So I think that what we want to do is really implement as quickly as possible, but make sure that there is enough time for folks on the provider side and on the payer side to be able to get off the ground.
Okay, so I think you have heard, Torrie, from a number of different corners of our state that we are very excited about this benefit, and people are really hoping that this will be coming soon, and therefore, and people are really interested in the whole thing. So we are of course hoping for sooner rather than later, but we're on board. So good to know.
I'm, thank you very much. I think that what I can share is that Judy Moore Peterson and her policy team is working on this every single day. And we have a really great collaboration with CMS, and this is really the first time ever. And so they have a lot of questions about how these things work, even on their own, in their own guidance. So it's been really fun to have like a little joint research project. However, having a joint research project gets in the way of serving seriously ill patients and families and building our workforce. So, we're trying to hurry them along as well. Brenda, you asked a question. You asked a question about whether or not the assessment can be done only over one day or over multiple days. It can be done over multiple days. It just needs to be completed. I hope that is a good response.
And to clarify, advanced care planning could be part of that assessment if they were if there were additional, as you laid out for us. Okay.
Absolutely. And then when somebody actually engages or is enrolled in palliative care services, advanced care planning becomes part of that ongoing package of services. So we would expect that advanced care planning is then part of the ongoing service.
Great. This year, there was a law passed that allowed physician assistants to sign a post. So how did they fit into this scheme?
PAs would be able to offer the initial assessments as well. So they would be able to deliver that initial assessment. They're also able to be the oversight for an LCSW who is performing advanced care planning. Okay.
Well, Torrie, awesome. I think you've done an amazing job. People have answered, have lots of questions answered. So, on behalf of Kōkua Mau and the folks here in Hawaii, I'd really like to thank you for coming. You feel free to stay. Thank you for this great presentation and also for sharing the slides so that folks can follow up with other questions. And Torrie has graciously agreed for us to record this so this can be up on the YouTube channel as well. So Torrie, thank you very much.
Thank you. Thanks for having me.
And I do want to say thank you for all that you're doing to help Hawaii. And we are all very clear that we would be the first state to have this palliative care services benefit. So it's that is really great.